Right. So we will continue our discussion, which we were doing about how to handle critical incidents. So yesterday we started from just differential diagnosis of tachycardia, and we discussed about the basic principles. I will just quickly revise the basic principle, that is any critical incidents, any abnormal thing which happens in the OR. So your approach will be call for help, and then you will be doing ABC, airway, breathing, circulation approach, and your resuscitation, uh, manage resuscitation, evaluation, okay, and management will go side by side. Okay. So this is the basic principle, and then you will be stopping something. Okay. Stop the surgery, stop any culprit agent. We discuss about my malignant hyperthermia. We discuss about local anesthesia toxicity. So that was the basic thing which we discussed. So we will just continue our discussion from where we had stopped yesterday, where we stopped yesterday. So, have you heard about bone cement syndrome? So, actually, in bone cement syndrome, in any orthopedic surgery, in which they are using bone cement, and that is polymethyl methacrylate. Okay, polymethyl methacrylate. So, there is a it's when it is mixed with its solvent, there is a hyperthermic reaction which occurs, and it can result in immunological response sort of thing, okay, as well as you can say embolism like effect. So suddenly there will be hemodynamic instability. Okay, so uh, like uh, like for example, in joint arthroplasties, like in knee, TKR, or hip. Okay, then when they are putting, there is always mandatory to have good communication between the surgeon and the anesthetist. Okay, and what's important that you anticipate, because it's a complication which will not occur suddenly, and you can anticipate before. Like now there are some cementless uh, knee surgery in which they don't use cement. This is one option. The other option is that they put it retrograde, and they open a hole distal opening, so that the intramedullary pressure does not increase too much. Then before they put the cement, as I told you, there should be good communication between the surgeon and anesthetist, and you need to correct any hypovolemia or any blood pressure or any like before they put the cement. You should correct whatever things are unstable before that. That like if patient is already hypovolemic, and then it if it occurs, the severity will be too much. Okay, so it's better you anticipate and you react. Otherwise, if it happens, so your approach will be the same. You will be giving some fluid, you will be you giving some vasopressors, okay, and as the same basic airway breathing circulation approach. Okay, so this is also a complication which can occur in a number of orthopedic procedures. Similarly, tourniquet in all orthopedic surgeries in which they are using tourniquet, you need to know that there are certain things which occur when they put the tourniquet, and there are certain things which are there during the tourniquet, and then there are certain things which occurs when they open the tourniquet. Okay, so when they put the tourniquet, before that they just milk, they raise the foot end, they raise the limb, whether it is upper limb or lower limb, they raise the limb and they milk so that they push the blood. So at that time, if there is fracture, okay, at that time, fracture or even there is some thrombus, so there at that time there may be embolism when they are milking. So in a number of proceed scenarios, it's not advisable to do a lot of milking. Okay, this is one thing. The Just a second, please. Okay, so this is one thing. Then the second point about it is if whenever they are putting the tourniquet, and there is extra around five even especially in lower limb around 500 ml of, you can say, auto transfusion. Okay, because the blood which is there, for example, in certain area, so one limb blood will go into the circulation. So it is just like autotransfusion. So any patient with limited cardiac reserve can go in overload. So you have to anticipate about it. Okay, so this is one another point. And then when they place the tourniquet, there is constantly there is sort of anaerobic metabolism occurring. Okay, and that area there is also tourniquet pain, chronic pain. So, which is not usually like it will depend on the time of tourniquet, the pressure. Okay, so it is usually taken by type C fibers. There are certain medications which you can use to avoid tourniquet pain. One of them is low dose of ketamine. And as much as the duration of tonic will be there, the severity of these problem will increase. Similarly, when they open the tourniquet, just like this is auto transfusion, when they open the tourniquet, it is just like 500 ml of blood loss. Okay, so it can cause, for example, if a surgery is going on under spinal anesthesia and now they have opened a tourniquet, so patient can have some sudden hypotension. Even in GA, this can occur. So it can cause a loss of even loss of consciousness, especially if like if the patient is elderly. Okay, or there is already hypotension, because all the debris, all the anaerobic metabolites will suddenly go into the circulation, and it can cause vasodilator effect. Okay, and it will cause and it can cause sudden hypotension. So if they are opening the tourniquet, maybe they should not open suddenly. They should open it gradually. You should give some fluid or vasopressor beforehand. Okay, and like you as I told you, you should just anticipate and act accordingly. Okay, you know, doctor, this Mr. Zishan, this is your from you. This is the lines which are coming. Okay, Iqra Mudassara, you are exam candidates, am I right? Assam Bhali. Okay, so have you, Iqra or Hassam or anyone from exam candidates, have you heard of never events in anesthesia? Yes. Anyone wants to answer? Iqra, Mudassira.
Yes, sir. These are according to the wrong route, wrong medicine, wrong patient selection,
Mm-hmm.
events occurring in the theater
So
perioperatively.
wrong route of administration,
Yes,
wrong
sir.
medication, wrong concentration, Okay. Then wrong
Yes,
patient,
sir.
wrong site of surgery, wrong site or side. So for that, a number of things. Like for example, if you think about the wrong, so there is a WHO surgical safety checklist. Okay, WHO surgical safety checklist, which we do to to identify the correct patient, correct site, concerns. Okay, any critical steps, any antibiotic or any specific equipment needed from the surgical side as well as uh, anesthetic side to avoid these things. Uh, you can just have a look. There is then sign in and check in and then time out and then sign out. Okay. So not only you will inform anything special you need, any concerns, like any special things you will be required, and at the time of sign out, when they, so you will be telling that what will be the post operative expected post operative course, whether the patient is going to ICU or HDU or anything you require. Okay. um, in this thing also there is requirement with reference to any specific blood and blood products needed, anything special needed. So WHO surgical safety checklist is a one of them. The with reference to, okay, no problem. So with reference to this wrong drug administration and everything, uh, what points you can use to avoid these things, Ikra, with
Sir,
reference
by
to wrong?
following this WHO safety checklist, we can
No,
avoid
no,
these
I'm
never
not talking
events.
about medications.
Sorry, sir, I couldn't get your point. What medication can
Medications.
be used to avoid
No,
these
no, no, no,
never
no, 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 no,
events?
no, no, no. Never events with reference to medications, like wrong medication, wrong
Okay,
correct. So
okay.
what are the steps you can do to avoid these things?
Sir, first of all, proper
Yeah,
labeling must be there.
I'm sorry.
Labeling must be there properly, and
The
the routes of administration should be mentioned.
labeling route, actually not
Staff
in the,
should be experienced.
no, just a second. Route, the medications should be properly labeled with concentration. The one who is
And
preparing the medication ideally should give it. Okay.
and
There should
double check everything along the way.
double check. Very good. Double check everything. Okay. And routes actually, if, for example, if there is arterial line or there is a specific route which is not suitable for that thing, so the route should be labeled. Like arterial line usually are taped. Their stoppers, their connections should be taped. There is actually color, like red colored line, sample line for the arterial. So these are the things which are important. Double check concentration labeling. So this is very important. Another important thing which can, that hospital policy, like department or hospital should have standard syringes size, like for 3 cc or 5 cc or 10 cc, specific syringes with specific concentration, so everyone knows that this is the concentration which is being used. Okay, so this is to avoid.
Sir, also color coding is available
Very
for
good. Labeling and color
anesthesia.
coding. There is a specific, like usually the medications which are high alert have a label of high alert. Okay. And there is a specific color coding. Usually yellow color for inhalation, sorry, induction agents, and red color for muscle relaxants. Okay. Green color for atropine or glycopyrrolate and things are like that. You can have a look on this thing. There is a concept of look alike, sound alike, LASA. Okay. So special care should be given to look alike and sound alike medication. So these are certain steps which you can do to avoid these things. Okay. WHO surgical safety checklist also avoid wrong side, wrong side, different thing. Even remember one thing. that I don't think so that any anesthetist across the globe will not face or see in the department by himself, herself, or by some other. So it's a known complication despite all the care it happens. So always anticipate these things. You know, okay. So what are other complications? So we yesterday we discussed anaphylaxis, local anesthesia toxicity, malignant hyperthermia, and now we have discussed some of the complications. Another complication which may be there in anesthesia, as I will just laryngospasm. Okay. So first of all, my question is that what is laryngospasm? Yes, Hassan.
Sir, it is a protective reflex in which involuntarily vocal cords approximate to each other whenever a stimulus or irritant is introduced to them.
Okay, it may be pain, it may be suctioning. Okay. Even
Sir,
if you
blood,
pinch, if
blood, sir, blood
blood,
touching the
yes,
vocal cords,
yes,
sir.
blood touch. Not only one more thing, even if there is pain, like
Sir,
unfortunately he have a habit across many anesthetists that we pinch the baby or pinch any patient. So actually this can cause laryngospasm. So we have to be very careful. I hope you understand. So if it happens, okay, usually it
sir.
will cause stridor. Okay, there will be unsound wanted sounds. My question is that can laryngospasm like picture, I'm using the word laryngospasm like picture occur while the endotracheal tube is inside?
Sir, it can only occur if the patient bites the tube.
Very good. Okay. If the patient bites the tube, otherwise, if the endotracheal tube is inside, it cannot cause laryngospasm. Okay. So now, step by step, what you should do at that time, immediately, what you should do.
Sir, initially 100% of oxygen
Okay.
uh, with a tight seal and a good jaw thrust.
CPAP.
Yes, sir, CPAP, and after that we will deepen the anesthesia.
Yes,
By
deep and
Ideally with
okay. How?
ideally with ideally with 10% of the induction dose of propofol.
Propofol or
Generally, sir, at this time laryngospasm breaks, but if it's still not, we can use very low dose hexamethonium.
okay. You are missing before that. You are missing few things. Number one, have you heard of Larson's maneuver? Pardon
Yes,
the spellings of Larson's. I don't remember the spelling. Larson's maneuvers is
yes,
painful stimulus just behind the angle of jaw. Okay, so it will
sir,
relieve the laryngospasm. This is one thing. Alongside propofol, lidocaine. Before lidocaine, propofol, you can even try lidocaine. Okay, then you did not tell about suctioning. Okay, as we mentioned, always call for help. Don't miss it. Call for help or assistance.
sir.
Okay. And then the
Sir,
this
but if the patient is biting down on the tube, so suctioning we can't do then until we break until the anesthesia is deepened.
of course. Actually, these are the things which not everything is appropriate in every patient. Okay. But these are the journal drill which you will be doing. So call for help, 100% oxygen, CPAP, deepen the anesthesia either by propofol, lidocaine, even open you, because at that time inhalational anesthesia will not work free. Okay, because there is airway obstruction, so it will not work. So either you have to give propofol, lidocaine, or as he mentioned, next step you will be trying to do that. You can even try to do suctioning in between, but as I told you that a number of times the patient has clenched the teeth. So this is, so now if we just think what are the things to avoid it? So avoidance of these things is, one of them is never extubate in light plane. Okay, light plane is one of the most big culprit. Try to do suctioning when the patient is still deep, because even suctioning itself cause laryngospasm. Okay, suctioning in deep plane. Okay, then extubate when the patient is fully awake. Another thing is that actually you have to be more careful if you have if you are using supraglottic airway devices like igel. There are more chances, because this can create a bigger problem. Okay, so I have seen some people trying to do suctioning while the LMA or igel is inside. Okay, in light plane of anesthesia till the time patient is awake, please don't do suction, because it will trigger the response. And if the endotracheal tube is inside, no problem, because the airway is secured. But if, for example, you are using supraglottic airway device and you try to do the suctioning in between, it can create big problem, because now you cannot handle the situation with LMA. LMA will fail because larynx has, like, as we told, that there is involuntary contraction of laryngeal muscles. So now you cannot, the LMA will not work. Okay, so now you cannot ventilate. So you need to remove the LMA actually. In this situation, if it occurs, you cannot rely on LMA. Now you have to remove the LMA, and you have to give the CPAP with your mask technique. Okay, and the other things will be the same. Okay, if you are not able to handle the
Sir,
situation,
sir,
yes,
I have two questions.
yes.
Sir, we practically use this lignocaine
Mhm.
plane for this purpose, but I've never read it in any algorithm. And secondly, sir, it is a practical question regarding LMA, exactly the point you were discussing. Is
Mhm.
this true that we should always take out the LMA in a bit of deeper plane?
It's actually,
Many see,
it's a gray area. There are
sir,
different school of thoughts. Some people extubate or remove LMA or even endotracheal tube when the patient is in deep plane, or
sir,
majority of us remove that endotracheal tube when it is in light plane. So always either remove in deep plane or remove when it is fully awake. Unfortunately, majority of our colleagues do extubate or remove LMA or endotracheal tube while the patient is in light plane, because there is when the patient is moving the limbs like anything, or it's fighting with the endotracheal tube, it doesn't mean patient is awake. What do you mean by awake? Awakefulness. When anyone tell?
sir, either spontaneous eye opening or head lift for greater than 5 seconds or
Yes,
purposeful movements.
purposeful movement. If you give a stimulus, if you give a painful stimulus, patient is responding, patient is trying to move their hand, even if eyes opening is not mandatory. Okay, but meaningful response to pain or meaningful response to anything. Okay, so awakefulness is meaningful. Then another, as you told, this head lift. If you try when the patient is just fighting with the tube or moving the hands haphazardly, if you remove the endotracheal tube of LMA at that time, there is high chance of laryngospasm. Okay, so at that time you just need to calm down your assistant, because at that time usually anesthesia technicians wants to finish the job, remove the tube and let them run away from the OR. So at that time you have to be very careful. In my anesthesia practice, I try to extubate fully awake. I am not a good lover
Actually,
of
sir,
Yes.
actually, we are not using either dexmedetomidine or analgesias and opioid analgesias in good quantities.
Hmm.
So either we should use judiciously good analgesic agents, like we
Mm.
should use judiciously, or we should use dexmedetomidine or such drugs. Then we should expect good awake extubations. If we are not giving adequate analgesia or avoiding these drugs, then it becomes very difficult for the patient.
Y- Yes, I agree to your point, but the thing is that, again, if you have to compare between awake or deep or in between, there is no consensus. It depends on the person's experience. If you, for example, if you are worried about exaggerated sympathetic response, you can give a small bit of lidocaine. You can give even 1 cc of propofol when the patient is fighting with the tube. But let the patient having good respiratory effort and good response rather than extubating in between. As you are mentioning about dexmedetomidine or good quality opiates, you are right. But again, actually, in the exam, when you are just explaining to them, tell that don't extubate in light plane. You don't need to extubate in front of the examiner. But I'm telling you, practically, it's always wise to extubate when the patient is fully awake. Again, my vote is with the awake extubation. There are only certain conditions in which you need not to have like increase IOP, increase ICP, exaggerated sympathetic response in the form of high blood pressure. Even at that time, you can give a bit of labetalol, you can give a bit of anything to control that response. Okay, but airway always has superiority. If you extubate and you are not able to hold, like for example, if you extubate deep, okay, now there is a problem of holding the mask, there is a problem of tongue falling and obstructing. What will you do then? People, what the people do, they put this airway. Okay, so just tell me one thing, is airway safe? Placing oropharyngeal airway is safe? Yes
No,
or no?
sir.
Huh?
No, sir, it causes the also laryngospasm, irritant to airway.
It itself is irritant. Just try to put your finger inside your mouth and you will come to know whether oropharyngeal airway is a nice thing or a bad thing. Just to
No, it
avoid,
stimulate gag reflex actually cause vomiting.
yes, it will,
Sir, is nasal, uh,
yes.
sir, is nasal airway better for this purpose if, we have
Very good.
extubated the patient with the tube?
Nasopharyngeal
Uh,
airway is nasopharyngeal airway will be much better tolerated as compared to oropharyngeal airway. Okay. But of course, availability of nasopharyngeal airway and nasopharyngeal airway itself can cause nasal bleeding or epistaxis like that. So it's always you have to do the risk versus benefit, what you need to do. Yeah, I have seen people putting airway throughout the surgery. Okay. I don't understand. I have never in my 20 years of career, I never put airway. I have seen 99% people around me doing it just to think if the tongue biting, if you just want to prevent tongue biting, actually you can just a big gauze in between the teeth, just like we do it in ECT or we do it in prone position, any patient in which they are doing the neurophysiology. Okay, so we just put a tongue bite. This is one thing. At the time of extubation, I'm telling you a practical tip that you can use the yanker. Please place the yanker in between the teeth. Okay, not putting all the way in the oropharynx. If you are keeping it constantly between the teeth, it will prevent the tongue bite. Okay, of course this you cannot tell in the exam, but or maybe you examiner will not like it, but actually it's a very practical way. I keep the yanker as my airway. I never put oropharyngeal airway right into the oropharynx. Okay, but I just keep the yanker suction in between the teeth. It prevents the tongue bite. Okay, so this is how.
Uh,
Yes.
Assalamualaikum, sir. Sir, sometimes at the time of extubation, patient clenches their teeth. They don't allow yanker even because teeth
Mhm.
are so much clenched, like they don't
You
open
will
the
you
mouth.
will place it before the clench.
Yes, sir. Why is it happen at the time? Why the patient does this? Why they
Does this?
clench? Yes, sir. Sir,
Actually, again, this is light plane of anesthesia. This is light plane of anesthesia, and another thing is that this is like you can say involuntary thing. It's not program. Patient is delirious. Okay,
yes, sir.
patient
Yes.
is delirious, not obeying to the commands. This occurs especially if you have done any nasal procedure. Okay, nasal procedure.
Yes,
Now the nose is packed or blocked, and the patient is uncomfortable, and he's not able to breathe through the nose, and this is causing a big factor with delirium. So this is actually what is delirium. Okay, this is what is
yes,
called as delirium because patient is not understanding, not obeying, and is not understanding you and not even remembering what he is doing. Okay, So it is always better. That's what I'm telling you. There is again two school of thought. Some people will say you can extubate a little early, but I'm telling you my personal experience. I never extubate deep. I extubate when the patient is fully awake. Okay. And then now next part of this question. This is a very common question that you are not able to relieve the laryngospasm, and now patient is desetting. Okay. And your patient is having bilateral clefts. So what has happened?
Sir, pulmonary
Negative pressure
edema.
pulmonary edema, sir. Negative pressure pulmonary edema.
Pulmonary edema.
Pulmonary.
So how it happens? What is the mechanism of negative pressure pulmonary edema in this time?
Sir, actually, patient breathes against obstruction. There is obstruction in upper airway. The patient breathes against that. It causes negative pressure.
This is a little non-technical. Try to be a little more technical.
Sir,
Yes.
forced expiration against a closed glottis.
Yes,
No,
patient
it's
is
Or
creating. Yes, this is the answer. Patient is creating a lot of negative pressure, but unable to breathe. So there are tiny capillaries which are ruptured, and there is you can say suctioning like effect. Like patient is creating a lot of, and this occurs more so in young muscular people than old or patient with weak muscles. Okay, there are chances of negative pressure pulmonary edema will be more in young patients. So they are creating a lot of negative pressure, and the glottis is closed. So there is nothing coming in. So this pressure is affecting the tiny capillaries, and there is leaking. Mr. Awais, can you just mute your mic? This is very irritating. Walaikum assalam. Okay. So what will be the treatment of negative pressure pulmonary edema? Any one person tell. Atif, would you like to tell?
Yes, sir.
Okay.
It's mainly supportive, and
What
we
do you mean
maintain
by
the
supportive?
airway. Supportive treatment will include CPAP, positive pressure ventilation.
Positive pressure ventilation, not CPAP. You will need to intubate.
Yes. Intubate and
Ventilate.
give positive pressure ventilation.
And PEEP.
PEEP.
Okay. Then you might need
We
to.
can diurese the patient.
You have to give
Diurese.
diuresis. Okay. If the patient is not maintaining the blood pressure, then you need to give something to increase the pressure and diurese. Okay. And it will subside. What else? What about morphine? What is the role of morphine here?
I don't think so.
Nitrate and morphine.
They should be avoided.
You have to give. Can you remember this Mona?
Give.
sir, there is increased pulmonary capillary permeability in the case of negative pressure pulmonary edema, I guess. So, and we are giving pulmonary vasodilator. Will not they exaggerate the situation?
I think it is to reduce the pressure.
Okay, sir.
Okay, it will reduce. Is there any role of steroid? Is there any role of antibiotics?
No steroids and
No role of
antibiotics are
steroid,
required.
no role of antibiotics. Okay. I think the thing is that here you are using to reduce the pressure. Okay. That's what I know.
Yes, sir.
Maybe I'm wrong. Mona is morphine, oxygen, nitrate, aspirin. This is with
Role of
reference to,
GT in vasodilation.
yes, pulmonary vasodilator. You can confirm it. Maybe I'm wrong, because this is a last resort. Usually, you should stop here. Okay, these will be extra things.
Sir,
Yes.
sir, I've read somewhere that the standard management only include two things, that is 100% oxygen and PEEP. The diuretics which we use, it's not a standard part of treatment of negative pressure pulmonary edema. We should only use this diuretics in the form of furosemide or whatever we are using when we are suspecting a fluid overload.
Exactly.
Cause
So
is only
actually,
negative pressure pulmonary.
yeah, you are right. I'm just telling you that sometimes it will be needed. Not in all. That's why this morphine nitrate is also extra. If they are asking you more and more, what else? What else then to you? Otherwise, you stop here. Okay. Diuresis actually, diuretics is not only for overload. Okay. Diuretics is to kick out the fluid which is there in the lungs. It's not matter. Diuresis is not necessarily for this one. It's not matter of overload. Okay, because if you remove, if you want to remove the fluid which is there, how will you remove? Only IPP on PEEP, and the additional thing will be diuresis. Okay, it's not to cause this one. Like overload. It's not situation of overload. It's situation that you want to pull out the fluid which is there in the lungs. Okay.
Sir, is
Otherwise,
intubation necessary in all the cases
it's step by step.
of negative pressure
Step
pulmonary
by
edema?
step. Actually, at that time, it will practical. Again, I tell you something. Practical conduct of anesthesia is totally different than theoretical answer. When they are asking you the question in the exam, they are expecting you to tell. Okay, you can say we might need to intubate and give positive pressure ventilation with PEEP, and still maybe we require diuresis if the patient is still having crepitation, not maintaining the saturation. Diuresis will help. Okay, and these are the things, the extra thing which you might need to do. I think if you tell like this, that's more than enough. Okay, but there is no role of steroid, there is no role of antibiotic. Similarly, even if the patient this one if the patient this aspiration, almost the same thing. In aspiration, there is no role of steroids, there is no role of antibiotic until it is fecal matter. There is no role of antibiotics. Okay, so almost same thing is for aspiration. Okay.
Sorry, Dr. Zishan, just one more thing. So, negative pressure pulmonary edema develops only when they are intubated and they're biting on the tube, isn't it?
No, if
So,
you extubate the patient, okay,
hmm,
and
hmm.
now there is reflexly there is irritation by any way. Okay, and now the
Oh,
laryngeal muscles.
yes.
Okay,
Okay. So
Sir,
they're in
there,
laryngospasm and then they're trying to breathe. Okay. Yeah. Okay.
okay, so that
Thanks.
sir, there
if
might be a
any,
stimulus post-extubation, no?
I'm
Like
sorry.
putting an oral airway or putting the suction after extubation. That might be the stimulus, I guess.
Yes, it's one of them. If now I have a little bit of doubt, please reconfirm. Is it not totally worth to mention about morphine and this nitrate in negative pressure pulmonary edema? If anyone can Google. Now I am myself is confused a little bit, because this is a stock answer. This is the last thing. If you have told everything, then these things will be there. For related regarding to Hassam, your concern, that's for sure that it's not only for actual overload, it's a situation of overload. So now, if you want to remove the extra water, you need to give diuresis so that according to the fluid shift mechanism, fluid will come out of the lungs. Okay, so it's not the real overload, it's a situation of fluid overload. Okay, so you will be doing like that. So bronchospasm, we discussed yesterday the differential diagnosis. So bronchospasm we had discussed yesterday. So you will either light plane of anesthesia, tongue tube biting, endobronchial, then anaphylaxis, pneumothorax, pulmonary embolism. All these can be mimicked by increased airway pressures. Okay, airway pressures. So your approach will be again airway breathing circulation. You will see whether the bilateral you will convert on manually, and you will auscultate whether the bilateral ventilation to avoid happening of this endobronchial, and then you can increase the depth of anesthesia. Maybe patient need muscle relaxant, maybe patient needs increase depth of anesthesia with inhalational agents or a bolus of propofol, and then you will go further. At that time, you can have, there is special devices which you can attach to do some nebulization. Otherwise, these inhalational agents themselves are causing bronchodilation. Okay. So if you have ruled out any serious problem like pulmonary embolism or anything, your approach will be just to give some something to relax the bronchial smooth muscle. Low dose of ketamine can also help, uh, though it's not practically useful, but still in the exams or you have to mention about aminophylline. Okay. So for intraoperative bronchospasm drill, it's like that. You will see the monitor, you will see the blood pressure, you will see anything like that, and you will be anticipating like that. Okay. Okay. So any other question up till now? Because actually, some part of the discussion was done yesterday, and you can have a look on our first part. So because I started with the tachycardia and differential diagnosis of tachycardia, and then here we just a few words about bradycardia because we did not discuss bradycardia yesterday. So can anyone tell me what intraoperative, what surgeries prone the patient to have bradycardia?
So laparoscopy surgery.
Only laparoscopy?
No,
Eye
sir.
surgeries, peritoneal surgeries, laparoscopic
Trigeminal
surgeries.
I
Oculocardiac reflex.
Trigeminal vega reflex.
if you use the word any surgery in which vega bond, this vagus nerve is involved, there are chances of bradycardia.
Bradycardia.
Okay, so cervical, anal, this of the eye, this ear surgery,
Peritoneal.
any surgery in which there is a peritoneal stretch. Okay, is there any? Again, I tell you something. Practically, some things are practical consideration. Atropine is not recommended to be given as a prophylaxis. Okay, but again, I tell you, this is again only my personal experience, not mentioned in the exam. But glycopyrrolate is a little different. If for example, if you give a little bit of glycopyrrolate as a prevention, it will increase the heart rate a little bit, and sort of you will have a margin if bradycardia occurs. Okay, so I have made it as my like standard of care that whenever I see the heart rate, if the heart rate is around 70, okay, and I expect that by any manipulation sudden bradycardia can occur, I give a hint of a touch of glycopyrrolate, like 100 mics or 200 mics. It increases the heart rate gradually from 70 to 80. And in case sudden bradycardia occurs, I have a margin. But atropine is never given as a prophylaxis. Atropine, because atropine is short acting, atropine will make the heart rate crazy. So it's never recommended to give atropine as a prophylactic. But glycopyrrolate, practically, this is, I'm telling you, a safety profile that you can give it. Otherwise, the most important thing is maintenance of depth of anesthesia. Bradycardia occurs during laparoscopy or this ophthalmic surgery or any other surgery. The most important the step is that always maintain the depth of anesthesia, especially when they are doing the stretch, when they are creating the pneumoperitoneum. Okay, when they are, even I will tell you something very interesting. When they are cleaning the vagina, when they are cleaning the anal canal, this is the time when suddenly bradycardia can occur. So it is always better to increase the depth of anesthesia around 2 to 3 Mach. Okay, because in our in the machines in which there is no agent analyzer, you cannot actually predict. Okay, so the only way by which you can that you can give a bit of propofol at that time. Okay, in the patient in which you have put LMA, it's again, this is again, there is a big debate among the people whether to use muscle relaxant with LMA or not. So again, I'm telling you my personal preference, because we have availability of rocuronium and sugammadex. I will never use LMA without muscle relaxant. It's my personal preference. You don't need to tell in the exam, but I'm telling you as a safety, if you have given muscle relaxant, it will prevent happening of laryngospasm. It will prevent happening of bradycardia, because your depth of anesthesia is good, and now the reflex you have broken. So this occurs when the depth of anesthesia is not good. There will be more chances of this reflex. Okay, so even this laparoscopy mediated bradycardia occurs also when the depth of anesthesia is not good. But so this is very important. So if you want to prevent, you have to do like that. Okay. And then another use of local anesthetic. Local anesthetic, like if they want to use it for the endoscopic surgery like colonoscopy, or they are putting doing any surgery in which cervical stimulation is there, it's always better to have some local anesthesia with the jelly. Okay, they can use some jelly before putting the trocar. They in the sorry, like they do it in anal procedures, like they do it in vaginal procedures. So always, it's always better to have a good depth of anesthesia. Okay, but it is said, nip the evil in the bud. Okay, so it's not their general habit to do local infiltration or the in laparoscopic surgery. They infiltrate with bupivacaine, which is of no use. So if you make a habit that when they are putting the trocar, ask them to have lidocaine infiltration, so that lidocaine effect will come quickly. Okay, and when they put the trocar, the response will be blunted. Similarly, as I told you, that your depth of anesthesia should be adequate when you are doing it. Another option with reference to laparoscopy is tap block. Okay, if you have given tap block, actually this will prevent the happening of this vagal response. Okay, so atropine is one of them. What is the other things which you can tell about the bradycardia algorithm?
Sorry, dopamine.
Dopamine,
Yes,
oblique,
sir.
epinephrine, oblique, isoprenaline. Okay. What about atropine resistance, in which there is atropine resistant?
Sir, glucagon, isoprenaline,
Glucagon. Okay.
ephedrine.
Yes. Direct acting. Okay.
Yes.
And not through anti-vagus, like not through vagolytic, direct acting. It's like dopamine or epinephrine or isoprenaline, glucagon.
Beta.
And another thing, and what next is
Pacing.
transcutaneous pacemaker. Okay, or transvenous pacemaker. So this is the step for bradycardia. Actually, we have discussed the tachyarrhythmias yesterday. Okay, so you can just review them. Okay, what else? A patient suddenly became unconscious, or you are dealing with an unconscious patient. How will you do what should be your drill? Either you are doing it in emergency, or your patient suddenly became unconscious. So what thing you need to rule out? What will be the differential diagnosis of unconsciousness? Neurological, endocrine,
Cardiac.
okay,
Cardiac.
respiratory,
Cardiac.
cardiothoracic, metabolic, okay. So like neurological, what can occur? TIA or CVA.
Stroke.
Okay, we are just trying to see what we need to see. Endocrine, hypoglycemia. Okay. Then this one, Addison's crisis. What else? Myxedema coma. We will just browse through each of them. Respiratory, pulmonary embolism. Okay. Severe pneumothorax or acute, sorry, life-threatening asthma. Then my MI. Okay. Critical arrhythmias. What else? Hypernatremia, like hyper or hyponatremia, like severe
Sir,
metabolic. So
shouldn't we should classify them into early and intermediate and late complication, like the complication of unconsciousness? Like, is there some concept like that for these complications?
what do you mean by early or late? Sudden, you are telling sudden or
Like, exactly, sir.
gradual? Sudden or
Sudden and
gradual?
gradual. Yes, sir.
Actually, I tell you something. For anesthetist is always sudden. Okay. Because gradual loss of consciousness usually is for like emergency department or other specialities. For us, we are dealing. We will not be called if there is it's gradual. Okay. Indifferently, we are dealing when patient is already unconscious. Am I right? We are not the primary physician to deal the patients in in between situation. We will be doing when the patient already is become your point is absolutely valid. I'm not saying that it is not valid, but here we are just trying to if you are having a patient with altered conscious level or unconsciousness, how will you approach? So first of all, we have chalked out what can be the problems. One thing I have missed is toxins. Okay, toxins or any addiction. Okay, now if I hope you understand my point.
Yes, sir, I do.
Okay, so now how will you approach? Like again, your approach will be the same: airway, breathing, circulation. You will be seeing that is conscious unconsciousness with hemodynamic instability or not. Okay. If hemodynamic instability is there, most of course it can occur in neurological problems as well, but usually more chances of cardiac or pulmonary involvement with hemodynamic instability. Okay, so your approach will be according to the hemodynamic. You will be giving some fluid, you will be giving inotrope or vasopressor. If like patient is not you again conscious level, you will assess with the either AVPU or GCS level. If the GCS level is less than 8, you will intubate, you will maintain, secure the definitive airway. Okay. And then your further approach will be like you will be doing, for example, ABGs. Okay. ABGs will rule out any problem with sodium or CO2 narcosis or PO2. Okay. So you will have some idea. You will check the blood sugar. It will also tell the blood sugar level. Okay. And then what else? What will you be doing? You can have some radiological study. Like chest X-ray will tell you something. CT scan will tell you something. So you will be going further. If anything is there, you will have 12 lead ECG to rule out any cardiac problem. So your approach will be airway, breathing, circulation, ABGs. Like you will be looking at further step by step. Okay. So then definitive treatment may be there. You might need to give some steroids in case of this like Addison's crisis or even mixed edema coma. In addition to steroid, you might need to give this T3 thyroxine. Okay, and then CT scan will tell you some of the neurological problem it has occurred. Anything else comes into your mind? Yes, Assam. Assam is where is Assam? Ikra.
Sir, long bones right employee.
Very good. Embolism can occur. Like like one of the reason for unconsciousness as like I will give you a scenario. Patient with long bone fracture about to be transported suddenly became unconscious. So fat embolism, thromboembolism will be a differential diagnosis. Okay, so if you did a 12 lead ECG and there is some cardiac problem, if you did chest X-ray, you find some whatever is there, you will anticipate accordingly. Okay, any electrolyte imbalance, you will go towards the scheme to manage that specific cause. You're like you as I mentioned, resuscitation, management, evaluation will go side by side. You will go do one thing and go further. And with reference to neurology, remember one thing that if, for example, you should not forget the word stroke code. Okay. Of course, there will be some neurological involvement, but as it mentioned in this ACLS algorithm, you should be considering about stroke code, all the things which with reference to stroke. So in that case, you will be doing like that. If any specific surgery you are doing and anything specific occurs, your first possibility will be according to that. Like if patient is undergoing TURP and decreased consciousness occurs, your indifferently you will be thinking about TURP syndrome. Okay. So you will be looking at the sodium levels and you have to monitor and either go for hypertonic saline or diuresis or managing the airway or things like that. So there will be one specific management of that cause and then there will be general approach. So general approach will be the same. Okay. So I think we have touch into, of course, if there is some toxin, you can go towards its relevant reversal. Like, for example, if you are expecting if there is flumazenil or this one doxapram
Naloxone.
or naloxone. Okay, so they can be used according to the situation. Alcohol, also thiamine. What else? You know about doxapram? What is doxapram? It's a CNS stimulant, okay? Benzodiazepine antagonist, flumazenil, and naloxone is opioid antagonist. Okay. Anything I missed with reference to unconsciousness? Yes, Atif. Okay, so actually, was it's prayer time here, and actually we had another session for medical students. That's why
Vasovagal shock, sir.
very good.
Sir,
Vasovagal.
one thing I want to ask.
Yes.
like in an unconscious patient,
Mm-hmm.
like what would be the expectation of examiner? Like they would like to the answer from us that we should follow the BLS algorithm, or the things you mentioned. Like from where we should start?
Airway, breathing, circulation, call for help. Resuscitation,
Okay,
management, and evaluation will go side by side. You will
okay,
evaluate
sir.
and you will act accordingly. Okay?
Okay, sir.
Because
Yes,
it can be anything. Am I right? So you will be
yes,
saying my initial approach, your initial approach will be airway, breathing, circulation, and then now again next step you will try to find the possible cause. Okay, in which there will be package combo deals, hypotension, hypoxia, and unconsciousness until unless prove otherwise, pulmonary embolism. Okay, uh,
yes,
any you find anything cardiac with hemodynamic instability, myocardial infarction until unless prove otherwise. So in that case, you will be doing 12 lead ECG. You will be sending the cardiac enzymes. You will card the cardiology. Okay, you will involve the endocrinologist. Like multidisciplinary team approach, you can tell. So actually, there are so many things in cardiac patient, in pregnant patient. A lot of things will go towards it. Like any predisposing factor, like any patient with fracture suddenly became unconsciousness until unless prove otherwise it is embolism. Okay, so things like that. Actually, they want to listen from you the approach. If your approach is correct, you will be good. Okay, so I need to stop it here, but I'm just showing you like some obstetric problems, neurological. We did not discuss about actually seizures, so I will try to have our following discussion, because now I will try to have systematic approach. We in last 5 6 sessions we started from general approach for viva. We discussed some points about table viva. We discussed one of long case of diabetes mellitus, and like we discussed one approach surgery based discussion. Okay, so I'm just giving you an idea how to proceed with, but of course the specific things we can target in our coming days. Okay, so these are actually some of the you will go to the this articles, and you will find I have there are very good emergency manual. Remember one thing, no exam is completed without critical incidents. So you should have a very good grip to this critical incidents. Like airway fire is one of the critical incidents. Sudden hypotension, hypertension, tachycardia, bradycardia, arrhythmia, hyperthermia, hypothermia. This is all critical incidents. Okay, so they have mentioned in a very nice way here, and majority of the things, the common thing will be remain the same. Okay, so I will just stop here. You can you can find this in the link. Go to the main link, go to the articles, then you will find ICU complications, and in the complication you will find all these manuals. You can follow any one of them. It's better if there is a specific algorithm is available, like for local anesthesia, systemic toxicity, or anything specific is there, you can go for specific. Otherwise, the basic things will be the same. If you are having embolism, you will give heparin, or you will go for the symptomatic, or as Atif mentioned the word supportive treatment. Okay, Atif is left already. So your approach will be like this. Okay, so inshallah, tomorrow we will continue from where we stop. Actually, we had a session on for medical students with reference to integrated medicine. So if any one of you is interested, is welcome to join after half an hour. We will have that session from Dr. Afsha Khatak. She is diplomat, American Board of Pediatrics. So because this is also one of my pastime, I have around 4,000 medical students on board, and I'm trying to, the concept of that one is make nipping birds blooming flower. Make, I will just write it and then I will sign off. Make nipping birds blooming flowers. Okay. let's help our juniors. This is another of thing which I'm doing. Okay. So thank you very much, all of you, for attending. And any one of you wants to discuss a specific topic, just drop a message to me and we will just try to discuss. Okay.
Thank you, sir.
You are welcome. Bye bye.